on this OSP clinical meeting. And this is Oculoplastics Symposia number 6. And we have successfully run 6 symposia and the 5 instruction courses in this work in this conference till today. First of all, I will request Professor Brasab to start this proceeding of this session with the recitation of Holy Quran, sir. Sir.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والعصر إن الإنسان لفي خسر إلا الذين آمنوا وعملوا الصالحات وتواصوا بالحق وتواصوا بالصبر صدق الله العظيم.
Jazakallah, sir. So, taking the opportunity, I will start with my own presentation first. Please, sir. And this presentation is about the stem cell transplantation in the difficult cases or irritable cases of ocular surface disorder like Stevens-Johnson, ocular pemphigoid, etc. So stem cell treatment started with these two questions: how single cell makes a whole body, and how damaged cell can be repaired. Stem cells basically has the ability to continuously divide and differentiate into various type of other cells. It was started with the bone marrow transplantation in 1968, and by 2001, first human embryo was created till the sixth stage. Every stem cell do have some properties. Number one, it should be capable of dividing and renewing themselves for a longer period of time. Number second, it's unspecified. Number three, it can generate or it can raise the specialized cells of any type. So undifferentiated stem cells can give rise to specialized cell by two mechanisms. One is the internal signal and one of the external signals. And the theories are there. So there are different types of stem cells which can be categorized into the embryonic stem cells, adult stem cells, or induced pluripotent stem cells. Embryonic stem cells, as the name is known, it's been it's been supplied by the embryo, and adult stem cells can be carried out from a living organism, and that anybody can give it. And induced stem cells or pluripotent stem cells are being prepared in the laboratories. We are generally using the adult stem cells. Among these stem cells, our target is the mesenchymal stem cells because they can generate into the limbal stem cells. So stem cells are been harvested from the bone marrow, adipose tissue, peripheral blood, and among them the abundant sources the adipose tissues. These are the some indications for which the stem cells are being used in the field of ophthalmology. In the trigium, we know that it's abundantly used. We can harvest the stem cells from the other eye, even the autologous serum from given, and the congenital disorder retinitis pigmentosa. And a few talks has been there for the treatment of the retinitis pigmentosa after that workshop. So, how the stem cells can replace the other stem cells? Number one, they adopt and they regenerate the limbus stem cells. Number second, it causes the paracrine effects. It causes anti-inflammatory agent and create a favorable environment. And it also suppresses the VEGF. Its immunomodulatory, its antibacterial, and it's also tissue homing capacity, which is that if stem cells being provided in some spaces, it's a residue there. It makes a home there and its ability to be there. So application is there. We can inject, we can give the topical stem cells, we can inject subconjunctival, we can use the blood infusion, intrastromal can also be given, and there is some soft methods. So as the autologous stem cells have been used, no ethical aspect are there. In Stevens-Johnson syndrome, you can see there's shallow fornixes, corneal conjunctivalization, corneal vascularization, hazy cornea, and the dry eye. It's a case. And first of all, we have performed the peritomy. And after clearing the conjunctiva or the limbal area and deepening the conjunctival pockets, basically what we are doing, we are exposing that limbal area. So, which is the natural habitat of the limbal stem cells. And after hemostasis without cautery has been achieved, we make small crypts with the help of needling, and that is how we needle all the way 360 degree and make small crypts. Okay. Then we topically apply and wait for that. There should be there in their site, like that. So your target is to make the stem cell to reach at their normal position or natural habitat of the stem cells. Then peritomy is closed and subconjunctival, the rest of the injection given subconjunctivally. Yes. Just no, no. The source of stem cells basically. There is a small video which can be played. So source of stem cells is basically mesenchymal stem cells, and the abundant amount of mesenchymal stem cells have been present in the adipose tissue. So we drive adipose tissue from the abdomen or from the thigh. Please play the video. So this means subconjunctival injection given, and conjunctiva being ballooned. So the peritomy, it makes the peritomy easy. Then the Caesar came. We start the peritomy in that case. There's a lot of bleeding, and we wait till the bleeding has been stopped. Then small clips made with the help of needling. This is the way we're making small grafts. And then this is stem cell being prepared in the lab. Then topically apply and wait. And the rest of the tissue has been applied subconjunctivally. Next slide. No, sir. It's been derived from the by the body. We have derived the stem cell from the adipose tissue. So up till now, we have operated the stem cell on the 10 patients. The 16 I been operated, and the most of them are the stem cell, the patient of Stevens-Johnson syndrome, 3 patient of pemphigoid, and the 1 patient of chemical injury. We have made a scale to report their improvement. So actually, there's not much improved. We can calculate on our Snellen chart, but we have make that scale improved, static, or the worse. Other treatment. All the patients, most of the patient has got improved vision. They said they are improving and they are seeing something. Yes. And the irritation again, and all the patients are reduced. Photophobia, they were unable to open their eye. Now they are opening their eye easily. And then eye opening, the windy condition. Even they are unable to open the eye in the fan air. So they are comfortably opening eye. And dependency of the eye drops, so the lubricant has been reduced in most of the patients. So we also make a signs of that patient. So corneal epithelialization, keratinized epithelialization reduced in 9 patients and remains static in 7. Corneal vascularization reduced in most of the patients. Corneal haze did not reduce too much. And the dry eye symptoms improved 15 patients, and the inflammation, this is the case. You can see a bony dry eye. Even the patient has put the drop just a minute ago. And after that, though corneal haze not improved, but there is some water on the surface. This is one of the excellent cases. You can see a long conjunctivalization of the cornea. We have made the peritomy, and this is the results of after a few months. You can see the transparency in the cornea has been improved a lot in that case. This is a pre and post operative picture of that case. One thing you should note that they were so difficult to capture the picture that we have placed the speculum to capture their picture before the surgery, and after that they'll be opening easily. Again, you can see a conjunctivalization of the cornea, and there you can see, have it. Another case, chemical injury, a quiet reduction, and the eye is not looking too much angry in that case. So stem cell provides a promising result in the severe cases of ocular surface disorder, and multicentric study is required. Thank you very much, sir.
That's amazing work and primordial work, and I think it's worth discussing. Of course, yes, and it's worth discussing actually. I've not done ocular surface reconstruction. We have an ocular surface reconstruction team. I leave it to them. My job just rests with forming the fornices, conjunctival refacing. So yeah, exactly right. Exactly. Eventually, that's what I end up doing. But the idea and concepts is fantastic. Just a few comments before our next speaker comes up is that, I mean, source of stem cells, mesenchymal, we talked about it. I think Bobby Conn and Don Kikawa several years ago talked about even orbital fat having the same stem cells.
Yeah, but one thing is there, the number of the stem cells.
Right.
So, actually, we require about yes, millions of stem cells
Right.
to be implanted, and our orbital fat cannot provide that. We extract the stem cells, and the dose of stem cells vary from about 30 ml of fat.
Right. Which we don't have here.
And you can see there is so much fat.
And actually, some people like idea of getting some fat out of tummy.
Anyway, yeah, exactly right. But the thing is that usually requires a general anesthesia, right?
Yeah.
That usually requires a general.
It does.
You can do it under local.
Yeah.
Okay.
Just as
You're harvesting it yourself, liposuction, or
Liposuction.
oh, fantastic. Yes, which is what.
we have a team, every specialized, but
Right.
it's very simple. I've
Right.
done post
Right. Okay. So autologous harvesting as well.
Liquefied fat is injected directly, or you have
You-
No, so
Process.
then it's been processed in the
Processed,
lab,
yeah.
and from the adipose stem cells, adipose tissue, they drive mesenchymal stem cells, and they are so much purified that it can be injected in CSF also for the other problems.
Right. And then the next issue arises is you should avoid variety of indications for these. The question is, do you really need a peritomy if you're going to be injecting this, or because it's an injectable, right? Eventually.
Yes.
Fine, it's good. And then what is your threshold to do simultaneous limbal stem cell transplantation along with these fat stem cells versus do you leave that at a second later date
Usually, actually, in these cases, there is no other
thing done?
Both eyes, they're affected.
So both eyes are affected. So
These are desperate cases, actually.
so then another thing is extension of the study will be unilateral cases,
yeah.
chemical injuries and stuff like that, where you have normal stem cells, limbal stem cells on the other side. Yeah.
My opinion is that the cost is big issue in this.
Right.
And I think the universities should come forward
Right.
to support this, because at the moment we are doing in the private sector. Although universities have got stem cell lab, but because they have got the bureaucracy to
Regulation,
so-
ethics approval,
Yeah.
the whole works as such. But it's commendable work and great work. I'm
Thank you.
happy to see this. And hopefully the numbers will increase. And maybe I should encourage you to present this in one of the international meetings as well. I think so,
Thank you.
with some form of imaging.
It is
included.
it's actually work of our common teacher, Professor Sahaf. You would have
Right. Okay, very good. Worthwhile, yeah.
So, should we proceed, sir?
Yeah.
Next presentation? So next presentation, I would like to invite Dr. Fahad Kamal, and he is presenting. He is discussing the COVID-associated mucormycosis. His presentation is actually against the Shogrover sepsis.
And I hope all of you have uploaded your presentations.
Good morning.
Yes.
Last year during COVID, some news hit social media and the electronic media. The one news was the black fungus hitting COVID-19 patients, and the other one, India records more than 4,300 black fungus deaths. So that was surprising, and I think India was the first country that whistleblower this infection, that was the COVID-assisted mucormycosis. So the topic was originally allotted to Dr. Ashok, and unfortunately he can't make due to visa issue, so I am giving. But I am presenting the data of Lahore General Hospital in this study. This was a case just like the other case. These were some patients post-COVID, and mostly were the diabetics which present to us. And these slides we have taken from the culture plates from that patients. So yesterday Dr. Farzat has discussed in detail all these, the pathophysiology. So I am jumping to the diagnosis. The challenges was the diagnosis. COVID and the aspergillosis were both reported to us, and the differentiated them was too much difficult for us. But the difference of the septate versus non-septate hyphae on KOH was landmark in this aspect. KOH for non-septate was definite that it's a mucor. So one can identify mucor in 5 minutes if you have a liaison with the microbiology lab. The histopathology and the medical imaging is also helpful. The hallmark in the medical images is the loss of contrast enhancement in CT, PNS and orbit. And as we can see, there is this all orbit has been filled by the hyperdense shadows, and the contrast, as you can see, there is some contrast in this eye, but this eye is totally devoid of contrast. So the challenge in this aspect was with the liaison. It was a multidisciplinary approach. So pathology, patho-radio, internal medicine, neurology, ENT, and neurosurgery. Even some of these patients were on dialysis. And also the maxillofacial team has been incorporated in many centers. But in LGH, we were lacking maxillofacial team. So medical treatment that was offered was the liposomal amphotericin B, but its availability and cost affordability was a major issue, as the injection was costing 35,000, and 3 injections per day for minimum 2 weeks were costing about 14 lakh per patient. And the medical fitness and medical cover and the systemic complication were another challenge. And amphotericin B, as we all know, were the relatively ineffective, and posaconazole tablets were also in black at that time. So their availability, and also they were less costly than liposomal, but the around 20,000 per day treatment was cost. So, and other challenge was the surgical treatment. So we have to choose among the two, private versus public, as the private sector was refusing the patient of mucormycosis cause of the counter contamination. And also, or and in the public sector, there is the pathology department was unreliable. We are not trusting on their reports about. And the other challenge was the eye versus life. Patients were refusing to for the exentration, and they are, so we have to counsel them that exentration may cease the aggression of this disease. So surgical treatment, if there is no ocular involvement, the first debridement was done by the ENT. If ocular involvement, then the debridement, uh, if the on dependent upon the degree of the involvement, and even we have done the exentrations in this case. Anesthesia fitness was a risk because high risk consent, ICU arrangement. So majority of the patient were done in local anesthesia. As so in Lahore General Hospital, in 3 months, there were 37 cases were reported, and 18 cases were medically treated, and the 19 were the surgically intervention was done. And at that time, we only offer the exentration for dead patients. So mortality was 10 patients died of mucor and its complication. And among the 10, 8 were those who were only on the medical treatment, and on 2 were that underwent the exentration or other surgical intervention. So as you can see, by surgical intervention, the mortality rate is 10%, but on the medical treatment, it was 44%. And the data was statistically significant that the surgical intervention has more survival rate than the medical treatment only. And the follow-up was also the challenge in this case, as the oral antifungal posaconazole was unavailable at that time, and the medical management for the complication, these persons were diabetic, hypertensive, with renal failure, cardiac failure, and the redebridement were the issue, and the frequent dressing is also the challenge. And the rehabilitation phase of the psychological and the surgical reconstruction is also, we are dealing nowadays with this, as 1 year has been done. And this is the last news, that was that the a rehab center was developed in India for such patients, and I hope in Pakistan we should also have a rehab center for dead patients. Thank you.
Thank you very much, Dr. Farhat. Now I would like to invite Professor Zahid Kumar Siddiqui sahab. He is our great teacher, to come please and give this for interferon therapy for the conjunctival neoplasia.
Bismillah ar-Rahman ar-Rahim. Can I make some comment about the previous presenter?
Yes, please.
It's great to hear from Fahad Kamal, and we see the next generation of oculoplastic surgeon. He was at one time trained with me, and he's the most appropriate person to deal with this disease because his wife is microbiologist.
Right.
So he gets the earliest diagnosis.
No, I think the credit then, actually, if we're talking about proudly about the next generation, I would dare say that the credit goes to your generation.
Thank you, sir.
And all of you all, Dr. Tayyab, Dr. Ibrar, because they are the ones who were instrumental in ensuring the future is bright for us.
Yes. And the challenge
Like
still
Dr.
goes.
Sadia and all these people.
Challenge still goes on because we see quite a few patients who've got they're blind, they've got third, fourth, fifth, and sixth cranial nerves, and seventh involved, and we are managing these equally now.
And if you're looking for indications for orbital reconstruction, what is now emerging is all the survivors of the mucormycosis who had exentrations and major defects, rather than just a prosthesis. Now actually a complex surgical rehabilitation mode is now coming in a big way. So just so you know. Yes, Dr. Tayyab.
I think we would like to hear back from you what type of complex surgical
Anyway, that's afterwards. Just I want to share the information that very good article by Santosh was published in the Indian Journal of Ophthalmology in June 21. So that gives all the details of how to manage mucormycosis, what are the stages, all that. And I will suggest our residents and those who are, I mean, here and going to here or going to face this challenge to go through that article.
So please share that on POA WhatsApp page. Right. It's a kind of review for more targeted towards residents. Squamous cell carcinoma still remains the top one in the ocular surface malignancies. But this is the catch point. Once it invades the basement membrane, then we call it invasive. So this is what present. This is our own patients. It's good to photograph, but also you write down and draw in your notes. And I have noted that if you examine it in red-free light or green light, then you see the typical blood vessels in tufts and hairpin-like blood vessels. And then if you stain it with fluorescein, actually you can demarcate the area of conjunctiva. Rose Bengal and Lissamine are not available, so we have got other problems regarding the availability. So intraoperatively, we use methylene blue to identify the extent. I would allude to one of the case series of 88 cases we reported from Punjab, and that included Amir Yaqub's center from Rawalpindi and Lahore General Hospital and Mayo Hospital. Interestingly, most of them were outdoor workers, but look at that, 9 cases of zero dermapigmentosum. I think this is the front we need to work in South Asia, because the consanguinity and repeated surgeries, and it's a big challenge. Excision biopsy remains the gold standard, and I find that this crescent knife is pretty useful to do the lamellar dissection. And you can get the clearance in the theater, and we usually work on the frozen section, so we get the results of clearance. But sometimes we get challenges like that, 360-degree involvement, and we removed and we offered the interferon therapy, but he said, my crops are ready for harvesting, I can't. And he disappeared and come back with the perforation. And again, for initial dissection, alcohol, a little dip of alcohol on the ocular surface helps to start the dissection plane, and we follow it by cryotherapy, or a very, if not available, because in the multidisciplinary operating room, the VR team is catching cryoprobe all the time. So we occasionally end up using diathermy. We find that the results of stem cells, autologous, are pretty good, even amniotic membrane. This is a beautiful painting. If you watch it, is in the corridor upstairs. Mahro maho anjum ka mahasib hai kalandar, ayyam ka markab nahi rakib hai kalandar. That is a famous poet, Allama Iqbal. So this was published in Pakistan Journal of Ophthalmology. And but we were using interferon at that time, and 91% resolution. We were able to monitor only for 3 months. The problem of follow-up in Pakistan. Although it was still had a bit of cost at that time, but people managing. Results were amazing. You can see, especially for the diffuse one, it is very difficult to excise all that conjunctiva. And you can see, so we used to take biopsy and start the therapy, and we had very good results. So the endpoint was 3 months, but sometimes we had to continue therapy even after that. Very few complications like pyogenic granuloma or filamentary keratitis or persistent hyperemia. More males in that as they were outdoor workers. So, but this drug has really sabotaged all our therapy because interferon has disappeared from the market. And now we get this, but it is very costly. I think it is 7,000, 6,000 rupees per injection. So it is
not available.
and still availability is problem.
And efficacy is also not like interferon.
So
I used this.
we would request that Pakistan Oculoplastic Association should work on that as well. And maybe Sundar, you can send us packets of interferon.
And the reason I say that is interferon is not available in Singapore either.
Yeah, right,
So we have to airflow it from India
right.
at a fraction of the cost the West charges. So much so that now Carol Shields, who trains Santosh Hour,
I know.
is buying from Santosh Hour. So you're talking about training the next generation. Now these
Right.
people are now teaching the West how to treat ocular
Okay,
surface
so
neoplasia.
that means we need to,
I'm happy to be the middleman without any commission.
we can perhaps plan about the Wagah border, and in the sweet box they can give. So we are working on alternatives, but as you know, mitomycin being used topically on and off cycle, it is not that effective, and it is more toxic. Anti-VEGF bevacizumab has been tried, but I don't know. What is your Farzad? Have you tried bevacizumab for this? No. All right. But to reduce at least the conjunctival neovascularization, it may help.
Yeah,
But if they are lost to follow, they end up even for exentration. So my initial study when I was at another hospital, almost 50% of our conjunctival squamous cell carcinoma, they were ending up in exentration. But I am really happy that after all that training and teaching, now it is very rare to see the exentration for ocular surface neoplasia. This is another lady who was breastfeeding a child, and so she got partial treatment, disappeared, although histologically proven, and she came back with the lymph nodes. And then she ended up with radiotherapy. So the message is, if we can have still it is available, it will work. We need to find out how India is manufacturing it. Maybe we can ask universities to do it. These are the, again, Allama Iqbal. Dile bina bhi kar khuda se talab. Aankh ka noor, dil ka noor nahi. He was plastic surgeon for the nations.
Thank you. Can I ask a question? Dr. Zahid, regarding this interferon, you are using it after the surgery or straight away before surgery?
When we had it available, we used to give one pre-op injection, subconjunctival.
Mm-hmm.
So when we start and then start the topical therapy, and as it is called immunoreduction. So by the time they are on the table, it is already reduced in size.
Oh, thank you.
That's a principle which is happening across the board. Concept of chemoreduction, immunoreduction. You're now making unresectable lesions or otherwise mutilating surgeries are now reduced to tumors which are otherwise locally resectable. The surgery is followed by adjuvant.
Yeah.
Again, immunotherapy or chemotherapy or radiotherapy or whatever it is. So that's a new paradigm in ophthalmic oncology.
Yeah. Yeah. Should I go? So our next speaker is Dr. Farzad Pakdel, and he'll talk about target therapy in thyroid eye disease.
And just to keep the conversation going until he connects his laptop. So there are 2 or 3 things which I think are still evolving, and I think we can put more emphasis in. And right from day one, I've been listening to presentations. 3 things I think which for ocular surgeons is going to be the new frontier. One is vascular malformations, the recognition, better diagnosis, imaging modalities, intervening without doing any major surgeries. And most procedures are now minimally invasive injection procedures. Second, with the other day, we talked about trauma. And I think the concept of just not orbital trauma, orbitofacial trauma. And congratulations to Pakistan. Yesterday, officially, the Pakistan Ophthalmic Trauma Society or Association was unofficially or officially launched at our airport session, and Farzad documented it. It's now making world headlines now, believe it or not. So that's trauma is one aspect. I think Dr. Zaid, we're talking about how many cases you have. And the third thing is ophthalmic oncology. And I'm actually now making a pitch even with Carol Shields' group, ISO, International Society of Ocular Oncology. They only talk about retinoblastoma, melanoma, retinoblastoma, melanoma, retinoblastoma, melanoma. And now we are now pushing for ocular surface neoplasms, ocular adnexal neoplasms. There's so many orbital tumors that were being shown time and again. So I'm now pushing for the terminology of ophthalmic oncology, where ocular surface, and ocular adnexal will be raised. With these things, we now conquered it. I think orbital surgeons, I think we've done a great deal. So compliments and all your hard work, sir. Over to you, Farzad. Sorry.
Good morning, everybody. So I'm going to talk about target therapy in thyroid eye disease. This is my conflict of interest. I was honored to write a chapter for immunotherapy and target therapy of this book. So we know that thyroid eye disease includes different pathogenic phenomena, including inflammation in the periorbital soft tissues or production of glycosaminoglycans, that's mainly by orbital fibroblasts and adipose hyperplasia, and finally other mechanisms that work on vascular factors. So when we talk about medical treatment of thyroid eye disease, we should consider if the patient is in active state or not, and what's the severity of the disease. So we know that this is the famous Rundle curve showing us how the disease progresses over time. You may see here we have phase 1, ascending phase, that inflammation starts like pain, swelling, erythema, then goes to a plateau for a while, then comes down, then goes to phase 4, that the inflammation subsides. If you look at the dotted chain that's showing severity, it mirrors the activity of the disease. And very interestingly, after the inflammation subsides, you may see there is a gap between this severity and activity. What does it mean? It means that after a while we will have kind of residual problems like proptosis, lid retraction in the patient. So Rundle curve is guiding us how it's going on. It was assumed that this course goes like other autoimmune diseases, like 18 to 24 months. But I will mention later that it's not correct now. So the philosophy of medical treatment in thyroid eye disease is to decrease the inflammation. And by decreasing inflammation, that mirroring severity will be less. So if you could start anti-inflammatory agent appropriately in phase 1, phase 2, and part of the phase 3, you may decrease the severity and residual problems in thyroid eye disease. And decrease the probability of operations. So we know that currently anti-inflammatory agents for thyroid eye disease include corticosteroids. That still is the first line treatment for this disease, external beam radiotherapy, anti-metabolite alkylating agents, and other agents. So in this very, very short talk, I will focus on the new paradigm shift in treatment of thyroid eye disease. It's not new. We know that in many autoimmune diseases or neoplastic disease, now we focus on specific culprits of the problem, not just like a gunshot treatment for these agents. So the main actually player in this ground is orbital fibroblasts, whether CD34 plus or minus. I will show you later what's the significance of that. So it's very, very well known. Rituximab was introduced in the market like 10 years ago for treatment of different kinds of the malignancies like lymphoma and inflammatory and autoimmune diseases like rheumatoid arthritis. So it was used for thyroid eye disease as well. It's a CD20 monoclonal antibody, and it has been shown that it can decrease the activity of disease, it decreases the TRAb levels. It's effective in the earlier stages of the disease, but we have reports that is showing if you start that kind of treatment in some patients with eminent this thyroid optic neuropathy, it may start the process and aggravate the DON. So to me, rituximab is not a good choice for patients that you think will go to the DON. So let's have a look what the literature says. In 2015, at the same year, we had two RCTs, one from Europe, the other one from United States. And very interestingly, Stan and colleagues from States showed that comparing to placebo, it didn't show any benefits. But Selvi and colleagues in Europe showed that it was significantly effective in patients with thyroid eye disease. So the literature is ambiguous in rituximab. And rituximab is not considered like a first-line treatment, but we can consider it in second or third line of treatment for patients with thyroid eye disease. One of the very interesting points in the pathophysiology of thyroid eye disease is the crosstalk of the TSH receptor and IGF-1. So it's where we knew the new agent. That's the only drug treatment therapy for thyroid eye disease that has been approved by FDA. Very interesting that even FDA has not approved corticosteroids, but has approved Tepro for thyroid eye disease. So we have several RCTs from Smith for the first time in New England 2017 that showed patients that received teprotumumab significantly decreasing activity, increasing quality of life, decreasing proptosis, and sorry, Ray Douglas and colleagues optic trial in 2020 showed that Tepro compared to the placebo significantly decreased the proptosis and increased the quality of life, increased the quality of life, decreased proptosis, decreased the inflammation. So FDA approved Tepro in Jan 2020 for thyroid eye disease. We know a couple of serious side effects of the teprotumumab, like muscle spasm, alopecia, GI problems, hearing loss, and other side effects. But it was very interesting. In different studies, you may see the adherence to this treatment was like 90%. So based on these amazing results, the Tepro is not in the first line of treatment for patients with thyroid eye disease. Why? Because it's very costly. So just for one course, it costs like, actually each vial costs for 17,000, and the whole course of that for 1 year is like $429,000. Still, we are not sure about its efficacy in this thyroid optic neuropathy. And we have some concerns about the side effects. So the other very interesting point is the cytokines operating in thyroid eye disease, like interleukin-6, that stimulate expression of TSH receptors in orbital fibroblasts. So tocilizumab was introduced, and a few trials examined the actual efficacy of tocilizumab in thyroid eye disease. To be very, very short, I can mention like Moriers and colleagues that in a randomized clinical trial showed that it could significantly improve in CAS score. Sanchez and colleagues also showed it can decrease the CAS score, increase quality of life. And recently, we can use tocilizumab as subcutaneous application. The other agent is TNF. So in a study, we looked at the TNF alpha agent as a single therapy. I may go faster, thyroid eye disease, and we observed that patients that could not take corticosteroid as the first treatment and received anti-TNF alpha agents significantly improved in the CAS score. And also we had 5 cases with DON. It was amazing that in 4 of those cases, they were treated and controlled by just anti-TNF alpha. So this is a sample of my own cases. This patient could not tolerate corticosteroids and was a poor, risk for decompression. And we started infliximab for a patient. Amazingly, he improved in inflammatory criteria and also increased in best visual acuity. So overall, we know we have limitations on biologic agents in ocular inflammatory disease, like the paucity of well-designed RCTs. We have still some concerns about long-term safety of these agents and long-term efficacy. And of course, the cost of these agents is another matter. Thank you very much for your attention.
As you told us last time somewhere else, this is not available outside America.
That's correct. And we'll have Professor Khwaja come up to get ready. Yeah, and you're right. I mean, it's not yet available. European studies have been done, but it's not CE approved or European approved yet. They're currently doing some trials in Japan to test the Asian population. The reality in terms of economics, we were in Chicago September Academy, where lots of papers on teprotumumab was presented. The real world prices is anywhere from 800,000 US dollars to $3 million per patient.
My God.
So I thought I should just put that out.
Yeah.
No, but having said that, in 2-3 years, we're going to get biosimilars. Just as how rituximab, when it came in, was very, very expensive, and eventually biosimilars came out. And we're using a lot of these. Humira came out first, and then a lot of biosimilars. Hopefully, if it stands the test of time, the toxicity is not a major issue. The second thing is, when rituximab was published initially, the Europeans were gung-ho about it. Americans were not very happy with it, and we talked about this before. Apart from the cost, there was real threat of mortality from rituximab. Thankfully, we don't see that with teprotumumab at this point of time. Now, the recent data seems to suggest it's not a one drug thyroid eye disease is taken care of. Now they're giving it as an adjuvant modality, and apparently they're showing that it doesn't really reduce need for decompression in compressive optic neuropathy, like Dr. Farzad was mentioning about it. So they're now giving teprotumumab, then they're doing decompression, then they're giving teprotumumab again. So the drug they're playing around with, so the final word is not out. Yes, sir? So, Dr. Khwaja, we're waiting for you to get ready, then we'll get, yeah.
I'm always, so even in Canada, I mean, I can't use it, it's too expensive, right? And I'm always very skeptical when there's huge money involved, greed always comes in. So I'm very skeptical when you have some people going around the world talking about this drug that's magic, even saying that, they saw people 2 years after chronic Graves' disease with chronic fibrosis reversed, right? With this drug. That's how magic it is. I mean, first of all, that makes no logical sense to me. And fine, I mean, the scientists in the lab can prove that as much as they want. That But secondly, I just think that when it's millions of dollars involved per treatment or whatever it is, you got to be skeptical, right? I mean, and really, so because money changes people and changes things and changes results as well.
But for the science behind it, there's still some science behind it. So let's figure out.
Sure.
Only time will tell. Yes, Professor.
They say that if somebody is having a chronic disease, tell him a medicine which is very costly, and he will come next day and get it.
So time is a great healer.
Time healing.
Medicine which will resolve the fibrosis in the eye and won't affect collagen or anything else in the body.
So I mean, you're right. I mean, so this is what they're showing now. It's only reduction of proptosis, and the best it was anywhere up to 6 millimeter reduction of proptosis, not the fibrosis that you talked about. You're absolutely right. And they said you can get up to 2 millimeter reduction of proptosis. That was claimed as the endpoint and success of the study. So, in the interest of time, we'll carry on with this.
cheaper.
We surgeons are cheap. Giving you Dr. Kwajat, who talked to us about conjunctival neoplasia.
Thank you very much, sir. So I'll touch the conjunctival neoplasia. So I'll start with benign epithelial conjunctival papilloma. So you can see the structure. It may be sessile or it may be pedunculated. But I'll be concentrating more on the ocular surface squamous neoplasia, which can be divided into intraepithelial neoplasia and squamous cell carcinoma, depending upon the histology of conjunctiva or cornea. So, risk factors for developing carcinoma are UV exposure, prior skin cancer, older age, male sex, smoking, HP, human papilloma virus, and HIV. So, rapid growth or presence in a young patient, we should suspect AIDS. So the non-invasive conjunctival or corneal intraepithelial neoplasia is also called dysplasia. Does not involve the underlying basement membrane and it is pre-malignant. Dysplasia means part of the epithelium has atypical cells, while carcinoma in situ means the entire epithelial thickness is involved with the atypical cells. And this is the picture. So it can be papilliform, sessile papilloma harboring the dysplastic cells, or it can be gelatinous, result of acanthosis and dysplasia. And the third variety is leukoplakic, caused by hyperkeratosis, parakeratosis, and dyskeratosis. These diagrams are of my own patients, which I have collected over the last few years. So, what we should do? Number one, observation. If lesion appears to be benign, so here comes our clinical judgment. We can photograph, make drawings, take OCT pictures and ultrasound, and we want to detect any growth or increase in size. So the conjunctival carcinoma in situ is slow growing, present and limbus, and larger feeder vessels indicate invasion beneath the epithelial basement membrane. Invasive squamous cell carcinoma is extension beyond the basement membrane into stoma. Squamous cell carcinoma is more aggressive when there is decreased immunity and in xeroderma pigmentosa. You can see this is in an 11-year-old child having aggressive squamous cell carcinoma on the medial limbus in both eyes. So features suspicious of malignancy include elevation, enlargement, extensive pigmentation, fixation to underlying structures and larger feeder vessels. And when it gets out of the eyeball, it involves the orbit and it can present as, this is squamous cell carcinoma of the conjunctiva, presenting as orbital mass. Sebaceous carcinoma is masquerade as chalasia or unilateral blepharoconjunctivitis. Some related lesions that may mimic the tumors include the ocular melanocytosis, oculodermal melanocytosis, nevus of Hota, nevus, primary acquired melanocytosis, and melanoma is another significant lesion. There may be capillary hemangioma, port wine stain with capillary hemangioma of the conjunctiva, lymphatic malformation, which were previously called lymphangiomas, pyogenic granulomas, Kaposi sarcoma, lymphoma. And so what is the treatment? The treatment in most of the cases is surgical resection, and it is successful in 85% of ocular surface squamous neoplasia. It has the advantages that it provides tissue for histopath confirmation, ensures tumor-free margins, and is cost-effective due to decreased medications and decreased office visits. So the principles of surgical excision are complete excision with a margin of 2 to 4 millimeter margin, no touch technique to prevent touching tumor during removal, double freeze thaw technique of cryo or application of absolute alcohol to surrounding conjunctiva or limbal cells. Orientation of the lesion should be ensured by marking with ink or with sutures so that the histopathologist knows which margin he is dealing. Uh, Diagnosis by pathologist is facilitated by immunostaining and providing data like age, sex, ethnicity, clinical progression of the disease. The pathologist's job is made easy. Another option is topical chemotherapy, which can be used as a primary treatment or as adjunctive to preceding or following surgical excision. Interferon alpha to beta, 1 million unit, is better tolerated but is expensive and longer treatment. Mild conjunctival hyperemia and follicular conjunctivitis, and subconjunctival perilesional weekly 3 million international units may produce flu-like features. 5-FU 1% solution has adverse effects like mild lid hyperemia, edema, and keratitis, is economical, and no refrigeration is required. MMC 0.02% or 0.2 milligram per deciliter is less tolerated, more effective, 4 times a day for 1 week and then 1 week treatment-free interval. So we give 3 to 4 treatment cycles, and fluoromethanol drops can be added if there is discomfort, and side effects include pain, hyperemia, keratitis, and punctal plugs may avoid the punctal stenosis. So again, the success rate of topical chemotherapy in OSSN is 85%, and you can choose any of the 3 drugs. In melanocytic tumors, MMC has been found to be better. So the other options, especially for lymphoid tumors, are immunomodulatory agents like rituximab and radiotherapy. And annual or more frequent follow-up is required because recurrences are common, and if there is malignant epithelial or pigmented tumor, a dermatologist referral is necessary to work up. So, last slide, a few seconds. So we try to take 2 to 3 millimeter of tumor-free margin and excise the whole of the tumor, and once applying the cryotherapy till it freezes, and then it is thawed and then applied again. So thank you very much for a patient listening. Any question or comment?
Yes, Dr. Tayeb.
You said that if the lesion appears benign, then we should wait and all those investigations. I will personally go for surgery. Anything which you think that there is a remote possibility of it being a squamous cell neoplasm, it should be, there is no harm in doing that. That's the first of the. Second is regarding this the excision of the this. You should. I think we also use crescent knife from the corneal side. It gives a better removal than the scissors. But anyway, this was small, so you just did not use it. Thank you very much.
When you remove the tumor from the conjunctiva, mostly it's not invading the conjunctiva. I have seen very few tumors invading the conjunctiva when we operate. So when we remove it, I remove it from the conjunctival side right up to the limbus. And the limbus is the only place where the muscle is, the tumor is infiltrating, right at the limbus. So I remove it at the end, and I treat the limbus more meticulously than the tumor bed.
That's exactly what you were saying as well. Yeah.
आप कॉर्निया से आ रहे थे ना? हाँ हाँ एग्जैक्टली थैंक यू सॉरी मैं गलत समझा सॉरी जी सॉरी और कॉर्निया जो है मोस्ट ऑफ द टाइम इज लाइंग जस्ट सुपरफिशियल नॉट इन्वेडिंग द कॉर्निया कॉर्निया इज कॉम्पैक्ट स्ट्रक्चर सो इट्स वेरी इजीली रिमूव्ड यस
So the maneuver is called an alcohol epithelectomy. Basically, you use 98% alcohol, which actually completely devitalizes and thing. Then you can do a lamellar excision if necessary with the crescent knife and the limbus. You're right. And the important thing about all of these tumors is the no-touch technique. You try not to touch the tumor side, but you try to touch the normal side, and then try to dissect everything out, and then the lesion comes off. Thank you very much, sir, Dr. Khwaja. I really appreciate it. We now invite the big man, Professor Sahaf, big in very many ways, and to come and share his perspectives and experience on dry eyes and its complications, which we all find annoying to manage, but actually is a cause of major morbidity in all our patients.
आगे बिस्मिल्लाह वो जब भी ड्राई आई का जिक्र होता है तो जैसे वेल देयर इज अनदर आर्टिफिशियल टीयर वो बड़ा महंगा है बहुत अच्छा है तो हाँ 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 एक्चुअली हमने जो ड्राई आई लिया ना वो लिया DHA वाला डॉक्टर साहब मेरी आंखों में खारिश होती है ना आप आर्टिफिशियल टीयर डालें दिस इज नॉट ड्राई आई इफ़ यू सी एक्चुअल ड्राई आइज तो आप हैरान हो जाएं ड्राई आई होता क्या है मैंने कहा था इसको ऐसे कर लो तो पता है मैं इनोवेशन करता होता हूँ और जितनी फ़ोटोएँ आ रही हैं ऐसे गर्दन टेढ़ी करके जिस तरह वो दे हैव ट्विस्टेड देयर आवर नेक्स्ट व्हाई नॉट स्टैंड लाइक दैट क्यों जी ठीक है ऑडियंस को देखता कौन है मुझे बताओ अच्छा जी बेस्ट बेसिकली देयर आर मैनी रीजंस फॉर डिक्रीज टीयर secretion and then there is a decreased secretion then there could be inadequate spread irregular surfaces and then exposure so many problems एक बड़ा वो नोशन है मैंने कहा कि वो कहते हैं जी ड्राई आई के साथ वो क्यों अल्सर क्यों हो जाता है जी इन्फेक्शन हो जाता है दैट इज़ नॉट द रीज़न ड्राई आई से there is a loss of water from the epithelial cells. They desiccate and fall off. That is the reason for the ulcer. Infection, that is a secondary process. Only a few of the organisms they cause they break through the epithelium, like gonococcus. Not all of them break through the epithelium. So it's a dryness which causes. Then all these problems you can see. They cause. Now the thing is, tear. What is tear? Tear is a mixture of majority water, salts, mucin, antibodies. All of these are needed for the proper functioning of the eye. Now, what are the disadvantages of commercially available tears? You put in a drop. That's how it is isotonic. मैं कहा भाई व्हाट इज आइसोटोनिक वो उसको पता भी नहीं होता व्हाट इज आइसोटोनिक वो उसको रट के आया होता ना कि सर इट इज आइसोटोनिक वेल यू पुट इन अ ड्रॉप ऑफ आइसोटोनिक सॉल्यूशन इट गेट्स ड्राइड अप एंड लीव्स द रेजिड्यू देयर So with each drop the tonicity increases. वो कहते हैं जिस डॉक्टर साहब वहाँ ठीक नहीं हुआ, कहते हैं कितनी दफ़ा डाल रहे थे, 6 hourly, put it 2 hourly. कहते अब भी और ख़राब हो गया, कहते put it half hourly. और इतने इतने पतीसे बने होते हैं, white crust all over. Because with each drop the tonicity increases. Then there is problem with the preservatives, obviously. And another disadvantage is they don't cover the inflammatory component, nor there is a microbial cover. So, in a dry eye, we need doing frequent washing with plain water. It washes away the debris, dehydrates the tissues. And then, if you use water, that causes a bit of irritation because not isotonic. We can use isotonic or subtonic secretion like pediatric saline. So how to prevent hypertonicity? We can use hypertonic solution or water in between and then frequent washing. Mucin, we are talking of each component of tear separately. We were talking of water, now we are coming to mucin. We have got lubricants which are used in place of mucin, and then antibodies. So many a time we need an antibiotic cover, which we tend to forget. In a dry eye, we need an antibiotic cover. एक ही बात जी, वो जी इतनी देर एंटीबायोटिक करेंगे तो रेजिस्टेंस हो जाएगा. You change the antibiotic, but you can't do without it in a dry eye. And dry eye, so what's the solution? I tell them to make a homemade eye drops. In distilled water or in saline, we put in 1 ml of Visogel for every 10 ml of water or saline. And that covers both the water component and the lubricant component. It's very cheap. It's very cheap. It can be instilled many times a day. Many patients are not using their drops frequently because it's very costly. Very costly. जी 1600 रुपए वाला भी आया, मैंने कहा अच्छा चुटकी बीच में वो डाल देते. So sometimes or many a times you need a suppression for the inflammation. We can also preserve water, punctus stenosis, goggles, like that. They used to ask in FRCS exam, they used to ask that how would you occlude the punctum? And they always used to ask what is the temporary occlusion and what's the permanent occlusion. And many people, I've seen many people here, they don't know what's the temporary one and what's the permanent one. So temporary may you just apply a bit of hot cautery on the mouth of the punctum, and in permanent one, we put in the cord inside the punctum so as it fibroses and closes. There's a wet goggles or wet chambers. We used to practice this very frequently. One of our residents, he went for the exam. हम wet chamber इस्तेमाल करेंगे, sir, they are not available. So he said, sir, we are using swimming goggles. So simple. And more important issues. These were just exposure and TS deficiencies. What about this facial palsy? I've seen electropion. So we have to operate. That's the point. What I want to stress is that dry eye is just not water and tears. It is something else also. So ectropion is corrected, he's better now. Cicatricial ectropion. Then we have to apply skin graft. Colobomas of the lid. Colobomas of the lid. We have seen children being prescribed just artificial drops or ointment on top of the colobomas. And if you put the ointment, you will see, if you look at it for some time, when he blinks, the ointment is just put away. And the tears tends to dry up in 4 or 5 minutes, not more than that. So we have to correct that. Facial palsy. So this is a gold weight implant I have designed. and we are using it in the. There is something peculiar about it. It has got two necks, and we stitch around the neck and it right in the position. So there we put it, and then there you can see. And then there is irregular spread of tear film. Thyroid. Shabir syndrome, we talked about it that day. Granulomas on the surface of the eye. It's again Shabir syndrome. Granulomas. We have to put in anti-amniotic membrane grafts and vitamin A deficiency. And then we have got a Stevens-Johnson syndrome. There are so many problems in these patients. Scarring in the conjunctiva, scarring in the lids, and then squamous metaplasia, all the glands being strangulated, and irregularity of the surface and whatnot. So, obliterated fornices, dystichiasis, obliterated fornices. So, these complications have to be dealt with separately. You can't say कि भाई अब तुम्हारी dry eye है तो बस artificial tear use करते. You have to deal with them as a complete patient. And then this is a very interesting patient. He was unable to open his eye. He had a Stevens-Johnson's a few months back and he was unable to open his eye. And this is his lot of local anesthesia and he can open eye only like that. This was his tendency, keloid formation. And look at his eye. अगर आप गौर से देखें, this is keratinized mucus, lid margin. This was rubbing like anything on his. Look at that one. This is keratinized. This has to be dealt with. इसको drops पे drops दे रहे उसका कुछ भी नहीं बन रहा. And then we put in mucosal grafts over here, marginal mucosal grafts. This one, ये देखें, marginal mucosal graft. And then, this one, ये देखें, look at him now. Smiling. ये जब आया था मैंने कहा क्या कर रहा है ये? Does he go to school? नहीं जी, ये कहाँ जी विवश कर रहा है. तो जब वो ठीक हो गया मैंने कहा अब क्या करें, कहते स्कूल जा रहे. So, 1/3 of limbus cells are needed for corneal health, at least 1/3. And then they can be lost in chemical burns and thermal whatsoever. So they can be autologous from the same other eye, heterologous, and they decrease the vascularity, there's better teeth. I think we just presented a paper on stem cells. We just. So, this was the patient with a chemical burn. We did a stem cell, it's clearing up. This was his final picture. So that was miraculous. Didn't expect that much. Then autoimmune diseases, rheumatoid arthritis, pemphigus, ये सारा कुछ. Look at that. They have got dry eyes, ulcers. They are not eye patients. They are patients as a whole. Yes. Denial, psychological problems, severe depression, contemplating suicide. My patients, I've been seeing for years, and you have to motivate them each time. Doctor, मैं तंग आ गया हूँ. I have left my drops. I left my drop. मैं नहीं डालता. You will become blind. At least you are seeing. So then you have to have a personal rapport with them. This is very important. ये आँख के पेशेंट नहीं है, ये आपके पेशेंट है. So we have to deal frequently with these problems, infection, inflammations. So solution, another brand of commercial. Multidisciplinary approach. We have to look after their medical problems as well. You have to advise them कि अब फलाना टेस्ट करा लो, फलानी चीज़ कर लो. you have to deal them as a human being, not as an eye patient. And of course, we have to do a local treatment. And this is very important. A lifelong follow-up.
Right.
They come to you, they get disgusted, they go to other people, and when they don't get the same appreciation or treatment, then they come back to you. And then they stay with you. और हमारा normally होता है कि when we see such patients, normal approach is refer to somebody else. But this is not the point. This is the difference between a human being and a doctor. So there are many there are other researches we are doing on the stem cell as well, as Salman has just concluded. But there are additional problems are more important than just lack of tears. So we have to play the role of a complete doctor. So antimetabolous. Just एक दो बातें और. Simple washing with water. This is very important. Washes away the debris, washes away the extra drug, and hydrates the tissues. So simple washing frequently is important with clean water. Thank you, ji. Shukriya.
Should I? Yeah. So our next speaker is Mr. Yasir Khan. He will talk about orbital fracture repair.
In the interest of time, this will be the last presentation. We'll have a little discussion. Yes. So while he's setting up, any quick questions or comments? I mean, dry eye disease, like Professor Sahab said, is one of the another challenging ones. Differentiate between dry eye symptoms from dry eye disease. They're two different things. And defining primary disease, autoimmune disease from secondary disorders. I think he showed cases of Stevens-Johnson's and a lot of other conditions. So having a nice algorithmic approach, there's newer terminologies coming in, newer agents coming in, newer immunological agents coming in. He talked about cyclosporin and all this stuff. I think it's really changing the way we are approaching dry eye disease. Like thyroid eye disease causes a lot of morbidity for our patients. A quick comment. Yeah, it depends. So the dry eye disease again is a complex disease. Depends on whether it's an evaporative disease, whether it's a margin-related disease, there's a primary aqueous insufficiency disease, so on and so forth. And depending on what the etiology is, and your point is, you're right. Amongst Asians, meibomian gland inflammation is quite badly managed in the earlier stages. So much that like thyroid eye disease with fibrosis, a lot of these glands go towards fibrosis and scarring, which causes more evaporative disease. So now one of the newer modalities of intervention is actively managing the meibomian gland dysfunction. They're talking about lipiflows. There are guys who are now doing lid margin treatments. The guys doing repeated massages of the eyelids. And a lot of dry eye practices now hire a nurse where the patients come in once a month and they're milking these meibomian glands as part of the dry eye management. I don't have the patients to do that. And so those are all the new. Dr. Zaid?
Just one very useful tidbit that we should have thermotech at that. When you go to sleep, the patient can be, this is administered ourselves.
Warm compresses, yeah.
That's very important.
Yeah, don't tell hot compresses. There's a patient, mother in America, who was told, give your child hot compresses for chalazion, meibomian gland disease. She said, I'm going to treat my child so aggressively. She burnt the eyelid. Entire eyelid went for cicatricial scarring, required skin grafting and so on. This was recently presented in Chicago as well again. So be careful about use of even hot and warm can be misinterpreted by our patients.
I wonder if nature has inculcated some treatments in our daily life. Wake up in the morning.
Massages.
And if you see, it's the same method all over the world. Naturally ingrained.
I tell my patients, don't rub your eyes.
You know what that does?
And floppy eyelids. Yeah. Anyway, yeah. So we'll just carry on with Dr. Yasser's talk, and we'll talk more about it.
Okay, thank you. So,
And it's appropriate. It's coming from Canada because this was described in Canada,
what?
Northeast United States.
What
The
was?
white eye blowout fracture.
Yeah, Dave
There
Jordan.
you go.
A good friend of mine. So basically, there's been some excellent talks on orbital fracture. I think at least 2 talks in this conference. So no need for me to go through all that stuff. So I thought I'd talk about a case for urgent intervention in what's called a white-eyed blowout fracture. First written up by a good friend of mine who's a Canadian oculoplastic surgeon in Ottawa. So many fractures, as you know, I always say about 95% of fractures do not need to be repaired, orbital fractures, I should say. And and even this one, if there's no entrapment, for example, and clinically they're okay, I would not repair per se. So just in general with blowout fractures, of course, we all know that the surgical indications are, diplopia due to, soft tissue entrapment, and of course, clinically significant enophthalmos, more than 2 millimeters, or to be honest, enophthalmos is a cosmetic complaint. I always ask the patient, you know what, does it bother you? And there's mostly men, but many men and women, it doesn't really bother them, so I actually leave it alone, right? So that's the other indication for doing it. Now, I know Farzad touched on it. Is there controversy regarding timing of orbital blowouts? And, I thought about this, and over the years, and that's what happens when you learn from experience, things change. And in my mind, I don't think there's a controversy anymore, although there used to be, and I used to talk about that in previous discussions. This was a great paper. It was a meta-analysis done by a oral maxillofacial surgeon, Jazari et al. It was done in 2020, and he basically looked at does early repair of orbital fracture result in superior patient outcomes. And I would really recommend people taking this down because it's a really great paper to read for managing your patients. And he basically looked at 3 things. He said, if you do repair in less than 2 weeks, there's a greater odds of complete recovery and lower risk of post-op diplopia and enophthalmos. If you do repair in less than 30 days, there's complete resolution with decreased complete resolution and with return to pre-op motility and its decreased restriction and diplopia. If you do repair in less than 4 to 8 weeks, there's decreased post-op enophthalmos. Right now, having said this, he did write that that the quality of evidence was deemed to be low in the papers that they reviewed, and meta-analysis was actually not possible. But I still think that based on those of us who've done fractures for a long time, I do think now that these numbers hold true. And for a long time, I read this paper by a very well-known senior orbital surgeon, Robert Goldberg, and he talked about early versus late repair, and I used to quote this for a long time, and he said that after 2 weeks, if they come to you after 2 weeks, it doesn't really make a difference, unless you get them within the first 2 weeks, but to be honest, now, I think that the sooner the better, in my opinion. And so, again, what happens, why does diplopia occur? As you know, it's entrapment, paresis, edema, hemorrhage. And I always wait about 1 to 2 weeks unless there's something where I have to take them in, unless there's one thing, which is a white blowout fracture I'll talk to you about in a second. Otherwise, waiting 2 weeks is no harm done because it does decrease the swelling and it gives you time to plan, your life and your OR and the patient's life. So again, when it comes to blowout fracture, there's something to be said about what's called Volkmann's contracture, which is really present in trapdoor fractures with entrapment, and early intervention prevents this. Okay, so that's a background on fractures and surgical repair. So what happens when you see a patient like this, completely asymptomatic? Obviously, he's a kid. He's not going to complain because they're kids. They don't complain. They just adjust and move on. I wish we could all be children. To just move on with life. But then, unless we're having symptoms that Farzad talked about, like nausea, vomiting, ocular cardiac reflex, and you can see here there's a limitation in the left, and that's where the white-eyed blowout fracture came about. It's usually present in children less than 16 years old, with little evidence of soft tissue trauma, severe restriction of vertical gaze, and really minimal radiologic signs. And Dave published this in the OPRS journal in 1998, so it's not a new concept. And again, white-eye blowout has nothing to do with skin color, obviously. This is another patient who has severe restriction on his right up gaze. And you can see, I mean, I've shown this CAT scan in the past to fellows and residents, and they've missed it. Even I would probably miss something so small and subtle. But remember, it's often a clinical diagnosis, and often it's not the muscle that's entrapped. Even fat can be entrapped, causing restriction. So symptoms, of course, as you know, are marked with restriction in vertical gaze. There's pain, often with ocular excursions, nausea, vomiting, and of course, as Farzad said, significant ocular cardiac reflex, which can be quite significant and symptomatic. And so it's really rewarding to repair these patients. It's an easy repair to do, and they're better immediately. You can see here is a small trapdoor fracture. So in this case, there's no benefit. I mean, this is a no-brainer. There's no controversy here. In this case, there's no benefit to watchful waiting. Urgent surgical intervention is needed. Another case of a patient post-op with complete, free upward gaze. So, Bob Kirsten, who's my mentor, published this in the Ophthalmology Journal many, many years ago about pediatric orbital floor fractures with direct extraocular muscle involvement, and they found that that 34 patients out of 34 patients, 22 had severe limitation excursions, and if you did surgery early, there was more rapid resolution of diplopia and immediate relief of symptoms. But again, this is common sense. You have to go after these kids who are entrapped as sooner the better. Otherwise, you sentence them to life of strabismus. And of course, trapdoor fractures are most common in children. Why? Because children actually have thicker, immature bones. So the bone actually bends and breaks in a linear pattern and then basically snaps back, right? Entrapping whatever is unlucky to have fallen down, whether it's fat or whether it's muscle, okay? In adults, you often get large comminuted fractures. They have thinner, everything thins as we age and drops, less elastic bone, and so it shatters and displaces, right? So, and that's like with any fractures in both children and adults. That's why sometimes adults involve themselves in some really high, like skiing and whatnot. When the older you get, the harder it is to heal if something happens to you. So, this is another patient who has a white blowout fracture. Again, very subtle. I mean, very easy to miss in the untrained eye, okay? And again, this just illustrates that white-eyed blowout fracture is really a clinical diagnosis, isn't it? Because a CAT scan can be really subtle, and especially if you don't get the 2 millimeter orbital cuts, you get 5 millimeter orbital cuts, and that's why I always make sure that when you order a CAT scan, get the orbital cuts, which is about 2 millimeters or less. Soft tissue signs of trauma may be minimal, and you get restricted vertical ductions, so you have to do forced duction testing. You can't do that in a child, so that's something that's done in the OR, but clinically it's pretty obvious given the history and everything. Another patient with a right blowout fracture, this is a left blowout fracture, I'm sorry. And you can see very, very subtle, hardly noticeable. And in the OR, once the patient is there, your forced ductions will be significantly limited. This is the right eye, it's free. This is the left eye, quite restricted. And if you've ever felt it, you know it's quite restricted. So I really think that if you don't act on these kids, even if you don't have the nausea and the ocular cardiac reflex, I really think if you don't act on these kids, if you delay the intervention, they will have persistent diplopia and will need to see your strabismus colleague, who will probably send the patient for OR anyways first, and will ask you to repair the fracture before he or she does anything to the eye muscles. So, blowout fractures, why does chronically, potentially, with delayed repair, you get diplopia? Again, it's the Volkmann's ischemic contracture. The extra muscles have no facial compartment. Direct trauma and ischemia to the incarcerated muscle can also explain why you get diplopia with delayed repair. And of course, paresis that can do to injury to the branch of the third nerve. In conclusion then, always suspect white-eye blowout fracture, and I wonder how, if you guys see, I mean, you must see this a lot here as well in children who are less than 16, pain with eye movements, nausea, vomiting, marked restriction of vertical gaze. Again, you may not get much on radiology, X-ray, the wrong CAT scan. Do it right away, treat right away. Watchful waiting is not going to help, and they actually do well, very well after. Good, thank you.
We'll be happy to listen to you. Okay.
We're out of time technically. I'll skip my talk. We can have discussion. If that's okay with you. Right. Okay. Do you want to go ahead? So even more on thyroid eye disease. Okay. In fact, the white-eyed blowout fracture or trapdoor fracture, ideally it should not be called a blowout fracture. It should be called a trapdoor fracture because blowout is where the bone is blown out and there should not be any entrapment. It was described 25 years ago as appropriate then. Sorry? I've told them that. In fact, I met him last week in Korea. I think Farzad was there. You know, he wrote, so all of these things were written at a time 25 years ago where the knowledge was evolving. And a lot of these terminologies need to be refined over time. Yeah, so it's really a trapdoor fracture, but keep in mind that it's not just a disease of children. You can have young adults who can have the same trapdoor fracture. We recently had a 65-year-old lady who had white-eyed, fell down, limitation, and you can have this at any age. And the younger they are, we want to intervene. So I've been asked to go ahead with this, so I'll just give you my perspectives on thyroid eye disease. I think with Professor Tayyab organized a webinar more than a year ago, where I shared my perspectives on thyroid disease. This is one disease I'm very passionate about, and I think we're still not doing enough for our patients. As you know very well, it is not just an ophthalmic disease, but it's an orbitofacial disease. And like Professor Sahaf said, how dry eye disease has psychological implications for the patients. These are also another group of patients who actually have depression, even suicidal ideations as well. So do not treat these diseases very, very simply. It is one of the most challenging things because there are no textbook paradigms, algorithmic approaches to management itself. But however, when you start managing these patients, it can be quite rewarding to manage these patients. This is a real quotation from one of my patients, and I'll read it out. I've researched my thyroid eye disease and know more about it than the 20 doctors that I'd seen earlier. Why were they sent to medical school? And that's a real comment from one of my patients. And that tells you how badly we are communicating with our patients, counseling our patients. Like retinoblastoma, there's one disease, they go to 20 different doctors, they hear 21 different versions of the disease and the management. So these are my disclosures, no conflict of interest, but we wrote a chapter on surgical management of thyroid eye disease. But I wanted for the youngsters in the group to let you know there are two major international thyroid eye disease societies. The UGOGO, which has now crossed about 22 years, and the International Thyroid Eye Disease Society. We are doing our next teaching course next week in Valencia in Spain. So those of you interested, please, you're all welcome. I go home, pack my bags again. I'm going to fly off for the teaching course. And Dr. Farzad, who actually put together a beautiful online International Thyroid Eye Disease Symposium, which is going to be available soon for viewers who missed it. He's working on it. So just to let you know, so there are good resource materials, current state-of-art stuff. So did you know that is the most common autoimmune orbitopathy? Sometimes we talk about idiopathic orbital inflammation a lot. We don't talk much about thyroid eye disease. Quite common. The lifetime risk for women is about 3%. 3 in 100 women can develop it, and 0.5% in men. Women are more commonly affected than men, but when men get it, it's a much worse disease. So keep that in mind. So don't trivialize it's just a women's disease. When men get it really bad, and like any other autoimmune disease as well. Do not forget the fact that children can get it. I just gave a keynote about two weeks ago in India, Oculoplastics Association of India, on pediatric thyroid eye disease, and 350 people in the audience. How many of you have seen pediatric thyroid eye disease? Only one hand went up. That means we are missing a whole bunch of children who actually have pediatric thyroid eye disease. We keep in mind, although you don't have to do much for these patients, keep in mind 25 to 30% of patients, the thyroid function can be normal. So I have clinicians who suspect thyroid eye disease, send them for thyroid function tests. Thyroid function tests come back as normal. Then they rule out thyroid eye disease. So do not do that. Thyroid eye disease is a clinical diagnosis. You can have euthyroid Graves' orbitopathy. So keep that in mind. So the only purpose of doing thyroid function tests is to identify associated hyperthyroidism, which you are obligated to treat, which kind of improves the symptoms, but more importantly, important for the life itself. Keep in mind high risk factors, smoking, age, gender, so on and so forth. We say leave the patients alone because it's self-limiting. But there are patients, if you don't catch up at the early stage when the fire is burning and you don't immunosuppress them one way or the other, consequences can be devastating. So in my practice, we have a very low threshold for intervention. And also we see it's probably one of the most commonly mismanaged, misdiagnosed disease itself. So I projected the calculations. Approximately there should be 35,000 patients in Pakistan every single year. And if you have 35 centers, each one of you would have 1,000 patients. And if you say we are not seeing these patients, either they're going somewhere else or they've gone somewhere else and told nothing can be done, they're all sitting at home. So it's a real disease, and I've not realized any population where it's any lesser than what is reported in the populations. Yeah, or it's burnt out, and the people have been learned to live with it, and we were not managing in the early stage of the disease. But it still exists. So we know about the consequences, that's in children. Farzad talked about it, but one of the important things which is coming now is it's not the fat, it's not the muscle, it's a fibroblast circulating in the orbital fibroblast, which differentiates into either fat, pre-adipocyte, or the fibrosis, and that's where you get the type 1 and type 2 disease. And what's now coming in a big way is IGF-1. Farzad talked about it, so that's where the immunological manipulations comes in. So in the earliest stage of the disease, if you see it where this fire is burning, is medical management. But once those end stage problems happen, increased fat volume, proptosis, fibrosis, then it's surgical management. We talked about the Rundle's curve. The only reason why you should know about it is the earlier you intervene, you're likely to change the natural history of the disease. Likely, I said, and return them back to baseline. They never come back to baseline, but actually approach a baseline. So in my practice, there are only 4 questions you need to answer in a patient with thyroid eye disease. Is it really thyroid eye disease? Because we sometimes are guilty of treating patients who have other causes of proptosis and treating as thyroid eye disease and vice versa. The second is it active or inactive disease? Because active disease where immunological manipulations comes in. Third, severity of disease is mild, moderate to severe, or severe disease itself. Remember, just because they have mild disease doesn't mean they're not suffering. And you have to assess the quality of life. And if you have mild disease with significant affection of quality of life, then you have an obligation to treat these patients itself. So thyroid eye disease is a clinical diagnosis. It's not a radiological diagnosis. It's not a biochemical diagnosis. If you have autoantibodies, TRAB alone is useful, but along with TRAB, TSI is also very useful. But you can have, like myasthenia gravis, all investigations negative and still have thyroid eye disease. So use your clinical judgment. Active disease, we talked about the inflammatory phase of the disease. This is where proactive management with whichever immunosuppressant or immunomodulating protocol is going to be good for these patients. How do you assess activity? Be aware of the clinical activity score or the inflammatory index that was described by Martin Moritz from Netherlands and Peter Dolman from Canada, also another Canadian contribution, right? And you all know about it, 3 out of 7 or more in the presentation, 4 out of 10 later on. And this actually follows what we read in medical school, Ruber, Kaller, tumor, dollar, functional laser. We read it in the medical school, primary medical school. It's extrapolation of the same thing. But keep in mind that you can have silent active disease, just as how you have a white-eyed blower fracture or trapdoor fracture. Just because they look white and they don't have the active erythema injection and all the stuff that has been described in the Yugogo photographic scale doesn't mean they do not have active inflammatory disease. A normal-looking patient looking like that, still white, can still have active inflammatory disease. So I call it the silent active disease, and SAD, S-A-D, that we miss the silent active disease. Likewise, you can have patients like these who have progressive visual loss, inferior field defects, and look at the eyes. Eyes are white. Still an active phase of disease, but right at the apex causing compressive optic neuropathy in these patients. So do not wait for all the florid erythema, florid injection, foreign curricular edema itself. So examples are mild disease, moderate disease, and severe disease. And Yugogo labeled severe disease or sight-threatening diseases only compressive optic neuropathy and exposure keratopathy, as you can see over here. But to me, even disabling diplopia and primary gaze or within 30 degrees is to me severe disabling disease. So much so that now I have patients who tell me I'd rather go blind in one eye than suffer from intractable diplopia because I can't drive to work, can't ride a motorcycle, I cannot function. And you and I had diplopia. Do you think we'll be able to function just because we see 6/6 with full visual fields? So to me, diplopia and primary gaze, like orbital fracture again, within 30 degrees is significant disabling disease itself. So principles of management, mild disease may or may not treat. Moderate disease, I think there's a strong indication to treat. You don't have to treat every patient's sight-threatening disease, an absolute indication. And do not forget to assess the quality of life. And these are where depression, self-affect, and how they function at work, social relationships at the workplace and home environment is very important. So management, quickly touching on about 5 minutes, it can be controversial and oftentimes confusing. Ensure that you do not miss endocrinopathy, and if the thyroid function tests are normal, actually there's no role for an endocrinologist. but you still have to measure the thyroid function test every 6 months because they can always develop it anytime. It's like a lymphoma patient. Even if it's a pure ocular adnexal lymphoma, you're managing and monitoring these patients every 6 months for systemic disease, and if present, to manage it as well. In terms of management, you can do observation or various forms of immunological intervention. And there is textbook management, and there's a lot of unconventional management. General principles, we know that charms, harms, so no smoking. Remember, there's primary active smoking, but we forget to ask about secondary smoking, which means another smoker in the house, or the concept of tertiary smoking. In other words, people have smoked in that room. There's no active smoker in the room. There's children playing in the carpets and the rugs and furniture. They're still inhaling a lot of these stuff as well. That's called tertiary smoking. So don't forget to ask about it. Selenium, I don't routinely prescribe, but there's some evidence about it. So mild disease, the way you manage can be conservative, observation, or you can argue towards medical management where the quality of life is significantly affected. Moderate to severe disease is where simple general shotgun therapies with steroids or any of the biologics or radiation comes in. Sight-threatening disease where you can do aggressive biological suppression or with surgery. Inactive disease, there's no role for medical management. It's conservative, and if it's disabling, surgical management itself. These are the high-risk factors. The older they are at presentation, males versus females we talked about. Risk factors are smoking, active, passive is very important, and comorbidities in my patients, the patients are the ones which are real high-risk factors. There are certain modifiable risk factors. You can't do anything about gender, but you can do a lot about stress and smoking, so on and so forth. Then you can go to the whole slew, including radiotherapy. Yasser, are you a big believer of radiotherapy? Just yes, no. Farzad, yes, no. Yes or no? See, you heard no and yes. That itself tells you how controversial the topic is. So steroids has been, I shouldn't say this, but the gold standard of management. It is not oral steroids, it's pulsed intravenous methylprednisolone. You're hitting them, giving them a break for 3 to 4 weeks, hitting them again, break to 3 to 4 weeks. That's my protocol. But the UGOGO protocol gave it every week, and we'll talk a little bit about it. So there's a new protocol which has just come out, UGOGO 2021 protocol, which is the original 2016 protocol plus mycophenolate. And they're now selling it as the first line. I say selling it as a first line agent, again, based on the Mingo trial itself. I don't use it for all patients, and I have my own protocols. We published a comparison of the old protocol. But take home message is there's no role for oral steroids, in my personal opinion. It's pulsed IV methylprednisolone, which, as you can see, is given as an outpatient treatment. You don't have to admit these patients to manage these patients. These are examples of patients who had mild disease, but you can see the significant difference with high dose protocol that I give, which is much higher than the 8 grams they talk about. The concept of cumulative toxicity has been misinterpreted over time. And they came up with this magical dose of 8 grams. 8 grams is continuous infusion of a gram every day for 5, 7, 8 days. But methylprednisolone is out of your system in 24 to 27 days. So if you're giving it more than a month apart, it does not accumulate over time itself. So that's an important point. You should think about it. When you have persistent active disease despite IVMP, then you can go to any of those agents. Again, the new protocol has gotten rid of methotrexate in the protocol because there's no evidence, really published evidence of methotrexate, although all of us use it. Or you can think about radiotherapy. This is an old protocol that you're familiar with, but there's a new 2021 protocol, and we are kind of signatory to that publication which just came out in 2021. And in mild disease, local treatment is very important, but the quality of life is affected. Consider medical treatment for these patients. And in moderate to severe disease, you can again give the same protocol, try it. There's no response at all. Then you go to second line, third line, fourth line, fifth line, so on and so forth. The second line is cyclosporin or similar agents. Third line is radiotherapy with steroids. Remember, it's not radiotherapy alone. Fourth line is rituximab, which is talked about it. Fifth line is where teprotumumab is now coming in based on the current level of evidence. And if you refract it to all forms of medical treatment, you have severe disease, you can still go to surgical decompression itself. So the Europeans still believe if they fail one complete course of IV steroids, you can go put them through it all over again. I don't do that because to me, if it's failed once, then you might as well go to the second line, third line, so on and so forth. So we modified the same protocol as such. Cyclosporin has a theoretical advantage against fibrosis. We now know diplopia is more disabling than blindness. It's very important. Remember, it's not steroids, but radiotherapy, it's steroids alone. Teprotumumab, I already talked about it. Very expensive drug, not yet available elsewhere in the world. Thankfully, we have this no problem of dealing with patients, but you will have patients, well-read patients who will probably read about it and ask you about it, rituximab, and finally tocilizumab. So what is the only role for oral steroids? Number one, when diagnosis in doubt, but I don't do that, you can give it along with radioactive iodine when they're treating persistent hyperthyroidism to prevent flare-up. Where there's no IVMP available, and that should not be an excuse to give oral steroids itself. And perioperative, I give steroids as well. We'll touch a little about it, but not as intermittent treatment. It is not as effective as pulse IV methylprednisolone. So I tend to now give orbital steroid injections for patients who have minimal symptomatic disease. Don't want to go through IV methylprednisolone. I give them 3 doses, 1 month apart, 30 milligram triamcinolone, targeted towards whichever muscle is involved. Is predominantly superior rectus levator involved, as in that medical doctor that you see over there. 3 injections along the roof of the orbit, 30 milligrams in the mid orbit, not subconjunctival. And you can see this return of function to normal. So that is coming in a big way. It is published but not established mode of treatment. Beware, it's like any other orbital injections. I don't think there's any published case of blindness following orbital steroid injection for this condition. Whereas about 20-25 years ago, for capillary hemangioma, somebody had given it with intravascular occlusion and retinal occlusion. So be always careful whenever you do it. And then I think Farza gave this, I'll skip that. So that's Dr. Ray Douglas, a good friend. You're right, there can be conflicts of interest, but science is science, and I think you have to accept it. And sight-threatening disease is when you go to decompression. It can be annoying because once you do a decompression, somebody who had no double vision suddenly can have double vision. You can spoil the quality of life, but provided you're able to restore them, alignment as you can see over here, and inactive disease. Examples of patients. So in summary, thyroid eye disease can be very challenging, but you have a good approach to these patients, handhold them, it can be very rewarding. My patients are quite thankful when they come to see me. There are lots of newer developments of non-specific and targeted therapies. Remember, it's not just activity and severity, but assess the quality of life. And finally, surgical and psychosocial rehabilitation is very important. Thank you very much for your kind intention. And I really appreciate the wonderful meeting that you guys have put together. I've personally learned a lot from all the presentations. Every time I interact with people, my first time in Pakistan, of course, the food has made me gain weight. I have to buy new clothes now. But great to see the wonderful work you all have done, and compliments, and thank you very much for your invitation. Thank you very much.
Thank you, Dr. Ganga. So, any question?
This what type of steroid are you using for regional, intravenous, and orbital?
Yeah, intravenous, what I use is IV methylprednisolone. So you make do. The truth is probably it doesn't matter which modality of steroids. The intravenous for us has been intravenous methylprednisolone. That's because in a university hospital, you have rheumatologists, you have neurologists, all using the same. We use an outpatient infusion service, where it's catered to our patients. Patients are admitted, IV drip in, cardiac monitor the first time, slow infusion over 1 to 2 hours. They tolerate it well, they get discharged within an hour or so. Orbital steroids, I tend to use triamcinolone. There is both triamcinolone with the vehicle and without the oily vehicle itself. We have only the one with the vehicle. That's why placing deep injections is very important, because you place it too superficially, you develop these white deposits. So it's a slow injection. So aspiration does not work as well to find out whether in the vascular lumen or not. Very similar to tissue fillers. So you've got to be very careful and just move the needle very subtly when you give the injection. So even if you're intraluminal and you don't know it, you're not staying continuously intraluminal, and don't use high pressures.
What is the dose that you were giving at a single time, and what sort of a needle are you using for it?
So to me, 25 gauge needles are the workhorse needles for orbital injections, whether you're giving anesthetic injections or whatever it is. These are sharp needles, not blunt needles. And the dose I give is about 30 milligrams. Literature is published anywhere from 20 to 40 milligrams per dose. Yasser, do you give orbital steroids?
Yeah, I use 27 8 forward, and I was asking what's your criteria, because it's actually in some cases worked really well, especially when they have that one muscle enlargement, like the inferior rectus is enlarged. It's actually I'm very surprised. I don't know why we don't do it more often. Is what I think. Something I want to see what your
Nobody has done randomized controlled trials. In fact, El Touki, I think from Egypt, has about 250 cases of orbital steroids. He's been doing for several years. The Koreans have been doing for several years. I've been doing for several years, but I don't have quite the same numbers, and I don't have a prospective randomized study. So these are patients who ideally will be needing the IV methylprednisolone 3 months or 6 month cycles, but they don't want to be bothered by coming in for infusions all the time. And like he said, it's just that one muscle, superior rectus with levator or inferior rectus alone, with disabling either lid retraction or double vision. There are some patients where quote unquote burnt out disease patients where after 3 injections, I actually give 10 units of Botox into the muscle itself, and I've reversed strabismus, but I dare not present it in such meetings and people start doing it. But 30 milligrams a month for 3 months. Some patients get dramatically better, they're fine even after 1 injection, but I still them, it's a protocol, it's a cycle. So you have to come for 3 injections. If it doesn't work by 3 injections, I don't give it anymore. Anybody else does orbital steroids for thyroid eye disease? Yes, sir. How your experience?
Methylprednisolone.
Right.
With the 2 cycle, because you mentioned the 6 cycles.
Yes, because it's a chronic disease. No point treating a chronic disease with just 1 shot treatment. So that's my belief. Then when you know the natural, that's where the natural history comes in. Rundle wrote that curve based on hyperthyroidism, and that has been extrapolated to active orbital inflammatory disease, and we kind of know that. Not everybody follows that Rundle curve. Not everybody follows that 18 to 24 months. Some people, the Rundle curve is only 6 months. Some people, the Rundle curve is 36 to 48 months. Some people get multiple Rundle curves. In other words, 10, 20 years later, they have another disease itself. So we believe in treating it for a significant period of time, and our published paper showed that when you treat them over 6 months, as opposed to the 3-month protocol of Go, the recurrence rate is much, much lower, and the response is much higher. How about orbital steroids? Do you give?
1 gram.
Orbital steroids. Orbital steroids.
Not a user. Not.
Can you just give us few tips about fat decompression? I mean, how to liquefy and hydrolyze it.
Right. Maybe I'll have the experts comment upon it, maybe Farzad as well. So there's, I don't know, the younger doctors know there's type 1 and type 2 disease described by Bill Nunnery. Type 1 disease is the fat predominant disease, and type 2 disease is the muscle predominant disease. Who's the youngest here?
Me.
Then I'm going to ask you the question. We'll ask my fellow moderator. Are most patients type 1 disease or type 2 disease? This is a catch question.
Sir, type 2 muscle involvement is there.
Second opinion. Dr. Sadia. Are most patients type 1 disease or type 2 disease? And I'm saying it's a catch question. All right. Yeah. So they're a combination of both. But they're predominantly fat, or predominantly Asians seem to have a higher preponderance of type 1 disease. I think the younger ones, typically the younger they are, they're predominantly fat predominant disease. To answer your question about fat predominant disease, not for muscle enlargement disease, tips on fat decompression is nothing but an exaggerated form of a lower lid blepharoplasty. You do a transconjunctival approach for the lower lid blepharoplasty for eye bags, but here instead of doing the anterior fat, you go to the mid and even intraconal fat. So you have to be a little aggressive about it, tease the fat out. And it only works for patients where you have a good retropulsion test in the clinic, not a firm, hard, woody orbit where the fat prolapses easily. And those are the ones you can do it. You can go medially also. I know endoscopically, do you do fat decompression, Farzad? There are surgeons who go endoscopical medial aort and suck out the fat from inside the cone. Farzad?
Yes, preference for orbital decompression is endoscopic medial.
Fat decompression.
Yeah, I do fat decompression, but not so much aggressively as Michael Kesem in New York suggested. So I use it like tuning my orbital decompression. Addressing your previous question about intraorbital triamcinolone injection, personally, I'm not a fan for intraorbital injection in patients with chance of the retrobulbar hemorrhage, compressive optic neuropathy, orbital compartment syndrome in the patients with limited compliance of the orbit, already inflamed, already large muscles. But IOS and thyroid disease is not just intraorbital process.
Closer, yeah.
Is not just intraorbital inflammatory process. So although you can temporarily decrease the intraorbital inflammation, but it's not like disease modifying or something. So besides, as you mentioned, we have no evidence how much cycles, how much effective in the long term. So personally, I'm not a fan for intraorbital injections.
So to summarize, fat is where it's not a fibrotic fat, but you have to have burnt out disease. I look at resistance of retropulsion. I go to the infratemporal quadrant first, infranasal quadrant next, and when doing an upper lid or even a superlateral bone decompression, you can actually do that. But I stopped doing a lot of fat resection from the superior orbit because suddenly these patients look hollow and skeletonized and give them an aged look. So I'm very conservative. Superior fat is more the inferior fat that I go, but you have to go for the intracorneal fat.
Thank you very much, Dr.
Sorry,
Ganga.
Ganga. I would like to mention when we are talking about orbital fat decompression, we are talking removal, not just
Right. Intracorneal fat. That's why I said intracorneal fat. You have to get into that space. And you just use an artery forceps to tease out, and the fat actually kind of flows. Gentle aspiration, almost like liposuction. You'll suction on it and you cut it out, or you can tease it out, scissors. You actually violate all your principles of orbital surgery. We tell them anything behind the septum, don't cut blindly. The thyroid eye disease is where we just, not blindly, but we kind of cut without cauterization. I don't even do that. That's the same. Yeah.
People that often with Graves, are more vascularized than normal, or the fat is
Burnt out disease. Go for burnt out disease.
Even then, there's fat vascularization, even in chronic disease I've seen, and so you can often get it. I mean, I found that when I've not clamped the fat, I've gotten bleeding, and that then you have to deal with the bleeding and whatever.
Dr. Sah?
Ji, when we are doing these procedures, don't forget the optic nerve compression. Optic nerve compression is not dependent on amount of fat or amount of pressure in the orbit. It could be an independent compression because of the swollen muscles in the cone. Right behind, they are pressing directly onto them. So we are busy in cosmetic and this, but we shouldn't forget that. And for that we need immediate decompression. And that is more not about the fat, but about bone, especially the medial rectus on the medial side. Because right at the back, the muscles are swollen and they are compressing on the optic nerve directly, even if there is no proptosis. That has to be kept in mind. पहले उसको rule out करें, then do anything else.
Yeah, what we do is, because the patients are not necessarily fit for general anesthesia right away, we do what is called an attempted medical decompression with high doses of steroids. See how they do in a month, by which time you optimize the diabetes, blood pressure, anesthetic clearance, whatever it is. And they keep having recurrent symptoms, transient improvement with recurrence. You're right, talking about posterior medial decompression. And another part which I think is very important for decompression of compressive optic neuropathy is posterior inferior wall, the palatine bone, which oftentimes is missed. And if you don't do that, those are the patients we actually feel we are under decompressing. The last point I would probably say, similar to fractures, keep a low threshold to image the patients you've decompressed. Earlier on in my career, I thought I was depressing or decompressing the posterior orbit, and look at your CT scan, you were nowhere near the apical orbit, and I was in the mid orbit. And all these millimeter rules and all the changes on the table, in the sense that we are not accurate. So as you start imaging your patients, as you decompress more and more, or do your orbital reconstruction more and more, your refinement of orbital surgery really improves. Thank you very much.
Thank you. So we are getting short of time because next session is going to start here. So here I got opportunity because we are reaching the end of the conference, and the next session will be the last one. So here I got opportunity to thanks all of the speakers of Oculoplastic sessions, especially our guests, Mr. Farzad Pakdil, Mr. Gangadhara Sundar, and Mr. Yasser. They are our guest speakers. We are really thankful to them because we have learned a lot and there was a very, very useful discussions. So thank you very much. And next is going. So next session after about 5 minutes, maybe. Thank you.